Hi, this is David Kettlewell, and welcome to Medical Matters, because life matters. All of us read in the news about Michael J. Fox and the disease he has called Parkinson's. We're going to be learning what is the disease and how is it treated in this program. I know you'll enjoy it. We'll be right back. We're talking about Parkinson's disease today, and I'd like to introduce our guests. We have Dr. Robert Plunkett, and you're with Buffalo General Hospital. Welcome to the show.
Thank you.
And we also have Pat Weigel, and you're a nurse.
Correct.
Great. Quick introduction. What's Parkinson's disease?
Parkinson's disease is a degenerative brain problem, and it manifests when the body loses a chemical called dopamine. And what does that mean for the patient? Well, it changes their mobility. They might get a tremor, they will get slowing of their movements, they will get rigidity of their limbs, their balance and gait may be affected, but it affects more than just the motor system. It also affects really pretty much the whole body. Some of the non-motor things that patients complain of.
Some of the non-motor things would be like thinking problems, slower thinking or memory problems, mood disorders such as anxiety or depression, speech difficulty, some bladder control problems or constipation, difficulty with handwriting. And then as the disease progresses, complications from the medicines themselves will cause them issue.
Is Parkinson's a disease which you can arrest to keep from it increasing in strength? Is it a disease which is reversible?
Not curable, not reversible, but very much treatable. It is a chronic illness. You'll live with it all your life once you have it, but it's treatable. And with good care, and for patients who learn about their disease and get educated about their disease, they can work with their doctor so that they can minimize the symptoms and maximize their quality.
You came on to Medical Matters, and we had fun conversations on the phone, and you have some really very clear goals for what you'd like to do in communication to this community about both the education that you do and the resources that are available. Why don't you, if you could, take a moment and describe to the viewers your thoughts about your mission and the role in what you're doing.
We'll do two parts. One, we treat patients with Parkinson's disease. We're part of a group at Buffalo General called the Comprehensive Movement Disorder Center. Movement disorder encompasses Parkinson's. And that group has a group of specialists who have focused their careers on Parkinson's. There are 3 neurologists that I work with, Dr. Kim Trinidad, Dr. David Lichter, and Dr. Tom Gattuso. And after doing medical school and a residency in neurology, they went on to do 2 more years of training specifically for Parkinson's disease. Then I'm part of the group as a surgeon, because sometimes during the management of Parkinson's, surgery can play a big role. Then we have Pat, who's a nurse who coordinates the program and works with the deep brain stimulators, which we'll talk about. And so it's a group of professionals who came together specifically to offer high-end care for Parkinson's. We can take care of anything from newly diagnosed all the way through surgery.
Do patients come to you strictly from referrals from other physicians?
Yes. One other piece, though, we didn't quite finish who we are. The second part of who we are is the outreach piece. So besides treating patients, we're also in charge of outreach in this area. You want to fill them in on that?
What that has to do with is support to the community, which means we just don't treat or support our own patients in our clinic. It's open to everyone in the community, no matter who your physician might be. So we have several support services outside of the medical treatment for patients and their families, because Parkinson's affects both the patient and their entire family.
It probably wouldn't be a surprise to most Americans that the average person could identify that Parkinson's involves the shaking of a hand sometimes. I mean, I think people kind of recognize that. But as you shared with me earlier, before the show, the extent of symptoms can go really far beyond that. Let's talk a little bit about some symptoms that present in patients, and our viewers can be thinking, gosh, they know somebody that has this, or do they? Or what are the various symptoms for Parkinson's?
Tremor is easy, as you said, but the other things that people might not really catch on to, they might just say, well, I'm getting older. They're slowing down in their movements. that same slowness of movement, if you look at someone's face and it's moving slowly, you'd think, gosh, there's no expression there. They're not smiling, they're not laughing, their face isn't moving the way it's supposed to. That's Parkinsonism. So that is part of it. When someone walks, their arms normally swing at their side. Well, with Parkinson's, as you walk, your walking would be slower and your arm swing might go away. So many ways, a slowing down that's more than just aging. That would be pretty typical as part of the presentation.
Okay. Some of the other symptoms that can present could include lightheadedness, memory problems, slurred speech and drooling, swallowing problems, nausea, constipation, diarrhea, weight loss, weight gain, change in handwriting, loss of dexterity, the tremor and the slowness you mentioned, impotence, decreased or increased sex drive, sadness, depression, loss of motivation, dry eyes, change in sleep pattern, vivid dreams. There's a lot of different things. Let's get into a little bit more of the actual science of Parkinson's. You mentioned this drug dopamine, or a compound that's in the body, dopamine. You didn't say that this is caused by destruction of myelin sheath.
No.
That's
no,
MS.
That's MS.
So it's not the myelin sheath destruction, which is a fat layer around nerves that just deteriorates and the nerves don't work well anymore. This is a chemical thing. Genetic?
In a small percentage of patients, it's known to be genetic. It might be in the others, and we haven't figured out what the gene is yet, but maybe 3 or 4% of patients, there's an actual genetic problem that leads to a reduction in dopamine. In the other patients, there is a reduction of dopamine, but we don't know why. And the widespread body systems that you talked about are indeed characteristic, but not usually at the beginning of the disease. Some of them are early, some of them are later on in the disease. And the treatment of the disease requires an individualized approach. You need to think, where's the patient in the disease, early or later? Are they still working? Are they not working? Which medicines could help this symptom but not that? And so the treatment needs to be individualized. And the important point is, in the last decade, we have 6 new drugs for Parkinson's. It's been a terrific time, a lot of new therapies, so that the outlook for treating the disease is improving. Not curing, but treating.
When is surgery, which is your area, you're a surgeon.
Sure.
When surgery called for in Parkinson's, what do you do and what do some of the things that you use in surgery look like?
Sure. Surgery is not an early therapy. Surgery is most commonly utilized in the mid to later stage of the disease, when the medicines are no longer as effective as they had been earlier, and the medicines then start to cause some side effects. In that setting, when a movement disorder neurologist who's working with the patient says, I've really manipulated the medicines as well as I can, and I don't have anything more I can do, that would be a time when surgery would be considered. And the surgery is to put an electrode, actually 2 electrodes, into the brain. And these electrodes, this is an example.
If you hold up the electrode over top of the black,
sure,
everyone can see it.
Okay.
Yeah.
So that electrode is placed deep into the brain, one on the right and one on the left. And then they're connected to a battery, and it's like a pacemaker battery. And then the electrical current is passed into these little areas of the brain, and that can ameliorate many of the symptoms. So it can improve the tremor, it can improve the slowness. And another problem that happens later in the disease is that the medicine will cause the patient to be squirmy. You describe it as Michael J. Fox whenever he's on TV. He starts doing this, and people think, oh, what's that about? That's an effect of his medicine. And the deep brain stimulation system can calm that very much. We talked about slowness of movement. Patients describe that when their medicine's not working right, they feel like they're frozen in the chair. And when the deep brain stimulation system is working, even though their medicine isn't working right, they can still get out of the chair and walk and move better. So it helps the motor side of Parkinson's. The constipation, the difficulty with speech, some of the other problems, it doesn't help. It's for the motor side of Parkinson's.
Why does this work?
For more Medical Matters television shows, go online to medicalmatters.tv.